Hello, my dear students. In this lecture, we will talk about drugs used to treat digestive system disorders. Introduction. Irritations or inflammation of various secretions of the GIT are identified as gastritis. Gastritis is an inflammation of the stomach. If the inflammation is colon, it is called colitis. If the inflammation is in ileum or in small intestine, this is called ileitis. If there is liver inflammation, this is called hepatitis. If there is inflammation in the gallbladder, this is called cholecystitis. The GIT normally contracts in a controlled rhythm to move the food through the different secretions. This movement is called peristalsis. When there is disorder in this peristalsis, this is called motility disorder. It is a term used to describe problems with peristalsis, such as cramping, diarrhea, and constipation. There are 5 main symptoms indicating a GIT problem, like nausea, vomiting, bloating, constipation, diarrhea, and abdominal pain. Pharmacotherapy of some of the digestive system disorders. The first digestive system disorder is a peptic ulcer. Peptic ulcer refers to any sore in the lining of the esophagus, stomach, or the duodenum, usually caused by bacterium called Helicobacter pylori or H. pylori. Drugs that are effective in treatment of peptic ulcer can work by two ways, either by reducing gastric acid secretion or increasing mucosal resistance to acid pepsin attack. Uncomplicated peptic ulcers are associated with H. pylori infection are treated by eradication of H. pylori with a combination of a proton pump inhibitor with a use of antibiotics. Two eradication regimens of H. pylori are suggested based on their efficacy, simplicity, and availability. These regimens are the use of either bismuth subsalicylate, which is a cytoprotective drug, with metronidazole and tetracycline or amoxicillin as antibiotic, or the use of omeprazole as a proton pump inhibitor with the use of metronidazole and amoxicillin. The second digestive system disorder is the irritable bowel syndrome, which is abbreviated as IBS, and the inflammatory bowel disease, which is abbreviated as IBD. First, we will talk about irritable bowel syndrome. It is a functional bowel disorder in which abdominal discomfort or pain is associated with a change in the bowel habit and with features of disordered defecation. In some cases, certain food can aggravate IBS symptoms and increase from the IBS case and should be avoided. In particular, lactose in lactose deficient individuals and gas producing vegetables like beans and broccoli, fatty foods and alcohols. This can increase the IBS symptoms. Second, the inflammatory bowel disease, which is IBD. It is a long-lasting problem that causes irritation and ulcers in the GIT. It is a chronic condition with intermittent symptoms. The most common IBD disorders are classified into two disorders, which are ulcerative colitis and Crohn's disease. In ulcerative colitis, the inflammation of the GIT mucosa is limited to the colon and rectum, while in Crohn's disease it could occur in any part of the GIT. The symptoms of IBS differ from the symptoms of IBD. As in IBS, there is no trace of blood in the stool or history of fevers or chills, but in IBD there could be a bloody stool. Medications that could be used in treatment of both IBS and IBD could include muscarinic antagonists. As you know, muscarinic antagonists block the muscarinic receptors and prevent acetylcholine from binding to these receptors, like atropine. These muscarinic antagonists decrease or reduces the GIT motility, so it could be used to reduce spasm in IBS. Anti-inflammatory corticosteroids and aminosalicylates could be used for treatment of ulcerative colitis and Crohn's disease. Also, antidiarrheal drugs could be used to decrease intestinal secretory activity and increases rectal sphincter muscle tone. Prokinetics also could be used, which are drugs used to enhance the activity of colon and restore the ability of the colon to transport its contents. Their main indications is in treatment of constipation. The third disorder is the GIT motility disorders. Here, the disorder in the motility of the GIT, like gastroesophageal reflux disease, which is known as GERD. It is a condition characterized by symptoms of tissue damage resulting from repeated or prolonged exposure of the lining of the esophagus to acid contents from the stomach. Proton pump inhibitors are very effective in relieving heartburn and healing erosive esophagitis. Also, prokinetics could be used like cisaprides have been reported to help in GERD and dyspepsia caused by delayed gastric emptying. The second GIT motility disorder is the gastroparesis. It is a delay of gastric emptying, typically seen in patients after surgery, trauma, or abdominal infections. Chronic gastroparesis is seen in diabetic patients. The third GIT motility disorder is the irritable colon, which is a common non-inflammatory disorder characterized by abnormal movements in bowel, which may consist of diarrhea, constipation, or both. The last two disorders, which are gastroparesis and the irritable colon, could be treated by prokinetics that could enhance propulsion of contents through the gut. The fourth GIT motility disorder is nausea and vomiting. It could be due to several causes like drugs, like cytotoxic drugs, opioids, anesthetics, and digoxins, or due to some movements like seasickness, or due to migraine and pregnancy. Vomiting is much easier to prevent than to stop once started. Therefore, antiemetics could be used or should be used before the emetic stimulus is expected. The fifth GIT motility disorder is the infectious diarrhea, which could be due to bacterial or viral infection. Most cases are self-limiting. There are several treatment strategies for treatment of diarrhea, like the use of anti-motility drugs, opioids, and antibiotics, or rehydration therapy. The sixth GIT motility disorder is the constipation, which is a passage of hard stools less frequently than the patient's own normal pattern. Laxatives and balanced diet, including adequate fluids intake and fiber, are of value in preventing of constipation. Here we will start in studying drugs used to treat several GIT disorders. The first is drugs used to treat peptic ulcer. Drugs used to treat peptic ulcer could be classified into three main categories, which are acid-suppressing agents, which could be further classified into antacids, muscarinic antagonists, histaminic antagonists, and proton pump inhibitors. The second class is the cytoprotective drugs. The third class of treatment is drugs for eradication of H. pylori. The first class for treatment of peptic ulcer is the antacids. Antacids are inorganic salts that can chemically neutralize the gastric acidity, like magnesium carbonate, calcium carbonate, and aluminum hydroxide and magnesium trisilicate. Magnesium hydroxide alone can cause diarrhea, and the aluminum preparations tend to constipate. So, we use both magnesium and aluminum containing antacids in order to offset their individual effects on bowel function, because magnesium alone causes diarrhea and aluminum alone causes constipation. So we can use both aluminum and magnesium in order to offset their individual effects. In renal disease, magnesium and aluminum ions may accumulate, causing renal toxicity. We're still talking about acid suppressing agent. We have finished the antacids, and now we will talk about muscarinic receptor antagonists. These agents block the effect of acetylcholine on different body organs by blocking the muscarinic receptors. Two subtypes muscarinic receptors, M1 in the GIT and the M2 receptor in the heart, have been identified. Pyridine drug is selected for treatment of duodenal ulcers because it has selective effect on the muscarinic 1 receptors. This is the structure of pyridine, contain pyridine and diazepine. Pyridine and diazepine. That is why it's called pyridine by due to presence of pyridine, zepine due to presence of diazepine ring. This drug is selective M1 blocker. The third acid suppressing agents are the H2 or the histaminic receptor antagonists like thymidine, ranitidine, and famotidine are H2 blockers, and they block the action of histamine on the cells and reduce acid secretions. Thymidine binds to cytochrome P450. As you know, this enzyme cytochrome P450 is important in the metabolism of several drugs like warfarin, phenytoin, and some of benzodiazepines and thiophanate. So, thymidine can bind to this enzyme and prevent the metabolism of these drugs, leading to several side effects. Ranitidine, being more potent than thymidine, it devoids of side effects of thymidine, but recently ranitidine is not indicated anymore. Why ranitidine drug not indicated anymore? Because it has recently proved that ranitidine contains a potential carcinogenic impurity called NDMA or N-nitrosodimethylamine. N-nitrosodimethylamine. This is the structure of N-nitrosodimethylamine. This is the nitroso group. This is an amino group containing nitroso, and these are two methyl groups. This is called N-nitrosodimethylamine, which is a potential carcinogenic impurity. Levels of this impurity was found to increase upon storage of the drug at room temperature. Recent studies found that after ingestion of this drug, which is ranitidine, and upon contact with acidic gastric secretion, resulted into accelerated generation of this carcinogenic impurity, NDMA. So, ranitidine isn't indicated anymore. Here are the structures of H2 blockers. This is the structure of histamine containing imidazole ring and the amino group. So the design of the antihistaminics are based on the structure of this histamine. Thymidine, which is not indicated anymore due to its side effects, containing also the imidazole and the side chain, but this side chain is longer and differs from the side chain of the histamine, but it contains the same imidazole ring. Ranitidine, the imidazole ring is replaced by the furan ring. Also, ranitidine is not indicated anymore due to presence of the impurity NDMA, which is carcinogenic. Now, famotidine is indicated as H2 blocker. We replaced the imidazole by thiazole ring and with a long side chain with sulfonamide at the end of this side chain. This is called famotidine. Famotidine is structurally similar to histamine, but we replaced the imidazole by thiazole, and there is a sulfonamide group instead of the free amino group, and there is a branched amino group in this side chain. We're still talking about acid suppressing agents. We have finished the antacids and the muscarinic blockers and the histaminic blockers, and now we will talk about proton pump inhibitors or PPI. Here this figure represents how proton pump inhibitors work. This is the stomach. Stomach has receptors like histaminic receptors, which work on the histamine, muscarinic receptors, which act on the neurotransmitter acetylcholine, and CCK receptors, which act on the castrine. On binding these transmitters onto these receptors, this will cause pumping of the protons in the stomach by the proton pump containing enzyme. This proton pump pumping the protons in the stomach and by reacting with chloride ions leading to formation of the HCl in the stomach. So the role of proton pump inhibitors is to inhibit these proton pump containing enzymes, so this leads to preventing and stopping the production of HCl in the stomach. Proton pump inhibitors like omeprazole. Omeprazole is inactive at neutral pH, but in presence of acid, it rearranges into two types of reactive molecules, which react with the sulfhydryl group in the HK-ATPase enzyme which is a proton pump. By preventing this enzyme, which is HK-ATPase, which is a proton pump, which is responsible for transporting proton ions of the parietal cells, this leads to inhibition of HCl secretion, and it is a powerful proton pump inhibitor. Here is the structure of the omeprazole. Here is the structure of omeprazole. Omi due to presence of omecyl. Prazole due to presence of pyridine ring. omeprazole وazole due to presence of diazole ring. So it is omeprazole, omi due to presence of omecyl, pra due to presence of pyridine, azole due to presence of diazole ring. This is omeprazole, which is a proton pump inhibitor acting on hydrogen potassium ATPase proton pump. We have finished the acid suppressing agents, and now we will talk about the cytoprotective drugs. Cytoprotective drugs are drugs that are used to protect the gastric mucosa, like sucralfate, bismuth subsalicylate, and misoprostol. First, we will talk about the sucralfate as a cytoprotective drug. It is a viscous non-absorbable polymer. It is a polymer of sucrose octasulfate and aluminum hydroxide. How sucralfate works? Sucralfate polymerizes at pH below 4 to give a very sticky gel, and then it adheres to the base of the ulcer and form a protective barrier against acid and digestive enzymes, so it can promote healing of the ulcer. Second cytoprotective drug, which is bismuth subsalicylate. It is also a polymer which acts in a similar way like sucralfate, but it has a strong affinity for the mucosal glycoprotein, especially in the necrotic tissue of the ulcer, which become coated in a protective layer of polymer glycoprotein complex. This bismuth subsalicylate makes complex with the glycoprotein, so it heals the ulcers more quickly. Bismuth subsalicylate and sucralfate should be given on an empty stomach, because if it is taken in a full stomach, it can make complex with the food proteins and loses its effect. The third cytoprotective drug, which is the misoprostol, it is a synthetic analog of prostaglandin E1. As you know, this is a prostaglandin which cyclopentane with two long side chains. This is a general structure of the prostaglandin. Misoprostol is a synthetic analog of prostaglandin E1. This is the structure of misoprostol. Prostol is called pre due to presence of prostaglandin, all due to presence of OH groups. It exerts its effect by inhibition of gastric acid secretion and stimulating secretion of mucus and bicarbonate from the epithelial cells. We still studying drugs for treatment of peptic ulcer. We have finished the antacids and the cytoprotective drugs, and now we will study drugs for eradication of H. pylori infection. Eradication of H. pylori is associated with a decrease in gastrin release. As we said before, gastrin binds to certain receptors on the stomach and cause HCl to release. So, by decreasing in gastrin release leads to reduction of HCl secretion and production of long-term healing of peptic ulcer. The most recommended drug combinations for treatment of H. pylori, like clarithromycin with omeprazole and metronidazole. If clarithromycin not used, we can use amoxicillin with omeprazole and metronidazole. Now we will talk about drugs used to treat irritable bowel syndrome and inflammatory bowel disease. The first class is the anti-inflammatory drugs. The second class is the muscarinic blockers. The third class are newer therapies. Now we will talk about drugs used to treat inflammatory bowel syndrome and inflammatory bowel disease. The first class, which is anti-inflammatory drugs. Anti-inflammatory drugs like aminosalicylates. Aminosalicylates are anti-inflammatory drugs such as sulfasalazine, olsalazine. Both drugs, sulfasalazine and olsalazine, are prodrugs, and their active metabolite is the mesalazine. These drugs, sulfasalazine, olsalazine, and mesalazine, are useful anti-inflammatory drugs for treatment of ulcerative colitis. Sulfasalazine is a prodrug. It is a combination of two parts, which is sulfapyridine. This is the sulfapyridine, and the second part is 5-aminosalicylic acid. This group is called salicylic acid, which is the benzene ring with carboxyl and OH groups. On 5 positions there is an amino group. This is carbon number 1, carbon number 2, carbon number 3, carbon number 4, and on 5 positions there is an amino group. So this part is called 5-aminosalicylic acid. Sulfasalazine has azo linkage. This N double bond N is called azo group or azo linkage. Could be broken by enzyme called azo reductase. Azo reductase can break this azo linkage to give two active metabolites, which are 5-aminosalicylic acids and sulfapyridine. So sulfasalazine is a prodrug. I want you to know that the part which is the 5-aminosalicylic acid is called also mesalazine. This part is called mesalazine. Here mesalazine is a 5-aminosalicylic acid. It is the active metabolite. It is an active drug and active metabolite of sulfasalazine. Also there is a drug called olsalazine, which is also a prodrug. Olsalazine, here you can note that olsalazine is two parts of or two molecules of mesalazine. Two molecules linked by an azo linkage. It is two molecules of mesalazine, but olsalazine is a prodrug. When it is cleaved also by azo reductase enzyme, it is cleaved into two molecules of mesalazine. Olsalazine is called also azo disalicylate. Azo disalicylate, azo due to presence of an azo linkage, disalicylate as it has two groups of 5-aminosalicylic acid. So olsalazine and sulfasalazine are prodrugs, while mesalazine is an active drug. The second class for treatment of irritable bowel syndrome and inflammatory bowel disease are the muscarinic blockers or the muscarinic antagonists. These drugs act by decreasing the contractions of smooth muscles of the GIT, leading to reduction in gastric acid secretion. Therefore, several muscarinic antagonists such as atropine could be useful in treatment of inflammatory bowel or irritable bowel syndrome, as they decrease the contractions of the smooth muscles of the GIT. Like atropine. Atropine is a muscarinic blocker. It has chair-like conformation and this ester group. Atropine blocks the muscarinic receptors and block the action of acetylcholine on these muscarinic receptors and decreasing the contractions of the smooth muscles of the GIT, and it is useful in treatment of inflammatory or the irritable bowel syndrome. Third class of drugs for treatment of IBS and IBD is the newer therapies. Newer therapies like monoclonal antibodies. Example of a monoclonal antibody is the infliximab. Infliximab is a monoclonal antibody and it is very effective in treatment of Crohn's disease. Now we will study drugs used to treat GIT motility disorders. As we said before, prokinetic drugs are useful in treatment of GIT motility disorders. Prokinetic drugs like cisapride, metoclopramide, and domperidone. These prokinetic drugs increase esophageal sphincter pressure and enhance peristalsis and gastric emptying. Cisapride has a certain mechanism of action, while metoclopramide and domperidone has another mechanism of action. Cisapride stimulates serotonin 5-HT4 receptors, while Domperidone and metoclopramide are dopaminergic antagonists. They block the dopaminergic receptors, so they can produce anti-nausea and anti-emetic actions. And here are the structures of the prokinetic drugs. Cisapride has piperidine ring and amide group. Also, domperidone has a piperidine ring and the two fused rings. This is characteristic for domperidone, while metoclopramide, meto due to presence of methoxy, clo due to presence of chlorine and an amino or amide group. These are the structures of prokinetic drugs. Cisapride is also characteristic by presence of fluorine in its structure. Domperidone, this structure, these two rings are characteristic for domperidone, and metoclopramide, methoxy, and the chloro are characteristic for this drug. Now we will study drugs used to treat nausea and vomiting. In order to study how nausea and vomiting is treated, we should know what is the source or what is the reason of the emesis. Emesis is coordinated by vomiting centers in the medulla in the brain. The most important source of stimulation of vomiting center is the chemoreceptor trigger zone, or CTZ. This zone or this area in the brain is not protected by blood-brain barrier, so it can be stimulated by circulated toxins or drugs. Transmitters involved in the pathway concerned with the emesis are not fully known, but the CTZ or the chemoreceptor trigger zone is rich in dopaminergic and serotonergic receptors, which are D2 and 5-HT3 receptors. So, by stimulation of these receptors leading to stimulation of the chemoreceptor trigger zone and leading to emesis. That's why dopaminergic drugs used in treatment of Parkinson's disease cause nausea and vomiting. We will study three classes of drugs for treatment of nausea and vomiting. The first class is the dopaminergic antagonist to block the dopaminergic receptor and prevent emesis or nausea and vomiting. The second class is the serotonergic antagonist, which is the 5-HT3 antagonist. The third class are the anticholinergic and the antihistaminics. The first class of treatment of nausea and vomiting is the dopaminergic antagonists. These antagonists block the dopaminergic receptors. Dopaminergic antagonists such as domperidone and metoclopramide, as we said before, domperidone and metoclopramide are prokinetic drugs, and they act by blocking the dopaminergic receptors, so they can reduce emesis and reduce vomiting and nausea. Combination of metoclopramide and dexamethasone is beneficial in chemotherapy-induced nausea and vomiting. The second class for treatment of nausea and vomiting are the serotonergic antagonists or 5-HT3 antagonists. 5-HT3 antagonists like ondansetron is effective anti-emetic. Ondansetron, its trade name is Zofran. Ondansetron is effective serotonergic antagonist, acts on 5-HT3 receptor. It works by blocking the action of serotonin, which is a natural substance that may cause nausea and vomiting. Ondansetron reduces the nausea and vomiting associated with cancer chemotherapy and of general anesthesia after post-operative emesis. Both dopaminergic antagonists and serotonergic antagonists are ineffective in treatment of nausea and vomiting motion sickness. This is the structure of ondansetron. This imidazole ring is characteristic for the ondansetron structure. Ondansetron is 5-HT3 antagonist. The third class for treatment of nausea and vomiting is the anticholinergics and antihistaminics. Anticholinergic drugs like hyoscine and antihistaminics like cinnarizine are used in treatment of nausea and vomiting due to motion sickness. Take care, the serotonergic antagonists and the dopaminergic antagonists are ineffective in treatment of nausea and vomiting of motion sickness, while anticholinergics and antihistaminics are effective in treatment of nausea and vomiting of motion sickness. Anticholinergic like hyoscine and antihistaminic like cinnarizine, and these are the structures of the anticholinergic drug hyoscine, which has chair-like structure, and cinnarizine, which is antihistaminic drug. Drugs used for treatment of diarrhea. We will study one drug for treatment of diarrhea, which is lopramide. Lopramide is an opioid. It has local effects on gut. It does not easily penetrate the blood-brain barrier, so it has less central side effects, and it is unlikely to cause dependence. Here is the structure of lopramide. And now we will study drugs used to treat constipation, like surfactants and stimulant laxatives. Surfactants are called stool softener. Example of a surfactant like docusate sodium, which facilitates the incorporation of water in the fatty intestinal material and softening the feces. And they are mainly used in hemorrhoids. Stimulants laxatives could be natural or synthetic. Natural, like castor oil and plant extracts of senna or cascara, and could be synthetic compounds like bisacodyl. These are the structures of drugs that used to treat constipation: docusate sodium, which is a surfactant, and the bisacodyl, which is a stimulant laxative. Here we have finished drugs used for treatment of GIT disorders. And please study the collective structures in the next slide. Thank you.